Hello and welcome everyone to this latest edition of the Asia Pacific TB Journal Club. My name's Harry Walker. I'll be co-hosting with Gail Cross. So I'm an infectious diseases physician and microbiologist. I'm now joining you from the lands of the Durrumbul people in central Queensland. We've got a great session planned for today. I'll hand over to Gail to introduce our speakers. But today we'd like to, at the invitation of our speakers, we'd like to run it a little bit differently in that if you have questions about the structure and nature of this research, please do sing out and ask the questions as we're going. And I'll endeavour to do the same. This is qualitative research as a clinician. Yeah, I'll hopefully represent some of the other clinicians in making sure I understand the methods in this paper. Over to you, Gail.
Thank you. Thanks, Harry. So it's my pleasure to introduce Associate Professor Sarah Bernays and her PhD student, Duy Trinh-Hoang. They're both social scientists based at the University of Sydney and the Woolcock Institute for Duy. Is that right, Duy? And they have a significant interest in really how we can bring community representativeness integrated into how we do TB research. So what the community feels and thinks about the research work that we're doing, since after all, it impacts them in the end. So can we make our research work more meaningful to them? That is the essence of their work. And today they're going to talk to us about a publication that came out earlier this year, where they looked at, within the context of a clinical trial, they looked at the application of a new tool, mHealth app, and how it was received both by patients as well as by people who, as well as by the healthcare workers. So I won't say more than that, but it was a fascinating paper for me to read, and gave me loads and loads of perspective on what we do day to day in our clinical work. Anyway. I'll hand over to Sarah and Duy, but before I do that, I would also like to acknowledge the traditional owners on the lands of where we're meeting. We're from everywhere. I'm in Melbourne at the moment. Harry is in Rocky, Sarah is in Brisbane, and Duy is in Hanoi. So we have overall a huge breadth of people whose lands on which we're presenting today. Okay, over to you, Duy and Sarah.
Thank you, Gail and Harry, and thanks so much everybody for inviting us to join your discussion today. As Gail has mentioned, we're going to be presenting the findings of a paper that we published this year from work that we've been doing in Vietnam. Duy and I have been working together for about 8 years, exploring using social science approaches, different ways in which TB outcomes can be improved, with a particular focus on making sure that the work that's being done is responsive to what community want and need, and also responsive to what health systems can absorb to ensure that any improvements can be integrated and sustained. We recognize that people are listening from lots of different places and also from lots of different kind of professional backgrounds. So we're really keen to make sure that this is useful and accessible. And so, as Gail said, we really encourage, and Harry, we really encourage you to ask any questions you want as you go, so that we can all kind of stay on the same page and we're being clear. Duy is going to present this work, but just to kind of frame that, we're hoping to kind of use this to prompt a wider discussion about the way we approach innovation within TB and the responsibilities that we have within TB research to develop interventions that can be accommodated within the system. And so as you're listening, these are two questions that we thought might be useful to talk about, recognizing there've already also been other questions submitted, and we'll make sure we're trying to cover them. But the idea that we often have for this kind of it's almost like an intoxicating or a beguiling desire for a discrete, neat solutions that can often dilute our engagement in developing responsive interventions that will work within health systems. And trials in particular are well suited to that notion of like a discrete idea, as of course it's emerged from essentially a discrete treatment often. But when we're thinking about the delivery of person-centered support, or how we might be able to deliver care itself, it's much more diffuse than that. And so how do those two exist in tension, and what can we do about that? And what are therefore the opportunities to extend social science within our research about interventions to make sure that they are designed to support system improvements? And as you're listening to Duy, I think if you could take that, like keep that in mind, that first image of the mobile phone dropping into the water being the system or the context, the mobile phone just simply cannot function in the same way, or the device cannot function in the same way when it's put into the context than when it's kind of in its glass protected box, which is often how we think about trial research, for example. And secondly, this image here about how we might have these beautiful conversations with a fantastic idea, but often completely shutting out or not adequately taking into account what's happening in the system. And this is not a function of this particular trial, it's potentially a function of the way that we construct our science and where we start from in terms of intervention design. So that's what we're hoping to try to cover in today's discussion. And I'm going to hand over to Duy now. Thank you.
Thank you so much, Sarah, for outlining and let us know where we should thinking about the finding. So since this is a qualitative study situated in the largest trial, so I will first give you the context into the trial and the challenge it kind of facing, and this study kind of try to aim to tackle. So as you may already know, MDR TB treatment is very long, and especially the medication, usually antibiotic, is you have a risk of inducing adverse event that could negatively impact treatment completion and outcome of the patient. So, and in this context of the overstretched health system, like in Vietnam, it is very challenging for healthcare worker and the system to actually monitor and manage AEs, since the patient have very, very diverse need and then live in very diverse circumstances. So people can live in the remote area, and then sometimes people, when they start the treatment, they can afford to stop going to work. So the idea was to capitalize on the expansion of mobile coverage, and vSmart kind of develop an app called Vaccine with Dr. Ming to enhance the communication between healthcare worker and patient as a way to improve early identification and reporting of AEs. So the patients basically, and every day they will go into the app and check into the app. They will try to report on the symptom that they were experiencing on that day, which might indicative of the potential AE. So the app will then notify the healthcare worker in real time on the other end and push them to act and respond timely. However, when the app was implemented into the routine care, and initially it garnered a lot of enthusiasm and the use is really high, but the engagement quickly started to wither over time. And this is the challenge from this qualitative study, which is conducted as a iterative approach to evaluate the intervention. As also, we also try to do this to provide some input to how to improve the app and the implementation. So when we started this study, we also noticed that in the literature of mHealth, this is a very common issue where many mHealth tools and devices that that was said to be promising and then liked by the user did not actually scale or sustain beyond the small pilot or small scale project, which is very paradoxical, right? Because like people kind of like it, but they don't use it. So within the V-Smart, we did a larger scale trial, and then it panned in multiple years. So it's not just a pilot. So we thought that the pattern kind of what we saw, the pattern what we saw kind of mirror the puzzle that we identify within the field of mHealth. So we think this is really good opportunity to investigating what is on it about, and then whether we can have an explanation to it and to use that to actually improve how we design and implement mHealth application more effectively. So we conduct in-depth interview with 25 patients in the trial intervention arm and 12 healthcare workers who are treating them. So basically they are doctors and nurses and then patients who are paired together via the app. So in our interview, we're trying to understand the reason behind the initial uptake in use and then the decline, and what should we make up the pattern and try to reflect how whether did it tell us about how AE kind of being managed and monitored in practice. So what we found is that is to some extent the initial enthusiasm was stemmed from the optimism for the potential of the app to support AE's reporting and communication. But it's really striking among patients that their decision to participate in the trial and install and use the app in the first place were not solely based on the expectation that the app and its function can actually support communication with healthcare worker, but it's rather they motivated because they see the app as the sign that healthcare worker actually care for them. So the app then symbolize an investment in care, and it become the main appeal for patients to install and use and experiment with the app at the beginning. However, over time, as they use the app, they did not see the functional value of the app because the function that the app offered did not actually have with what they expect for AE reporting. For them, AE's reporting and management in practice is very complicated. So healthcare worker, for example, they report that the patient could not figure out exactly the way to report their symptom. So they could not choose in the app within the redefined symptom on the app. They could not choose because like sometimes they feel abdomen pain, but for them it's not like the abdomen pain that they thought of, and then they kind of opt for more open conversation to actually describe what they were experiencing. Right, and sometimes the AEs might be is not really connected to the treatment itself, because like healthcare patient also have like other concern around their treatment. Also, that's where the app did not cater to them because they don't have those kind of concern being reflected in the design. So and then healthcare worker as well, they need to provide support emotionally to patient, which is not really, sorry, Gail, I think you have a question. I might stop here. So
oh no, it's fine if you wanted to continue. I was just going to say, Zui, one of the things when I was, so just for everyone who may have attended a little bit late, we're going to do a different format. So if you have any questions and anything comes to mind, please feel free to, pop it into the chat or raise your hand and ask. Zui and Sarah's preference would be very much for this to be interactive, because I think we could get a lot more from it rather than just, questions being saved towards the end. So my question, Zui, wasn't a question, it was more comment. I think one of the things that came to mind at first when I came to know about vSmart, the app, was that the whole idea of the app was developed on the premise that there was only consideration for adverse events from the drugs. You know, it was very, as you say, it was very discreet. There are many things in my experience that patients are concerned about with regards to having TB, getting TB treatment, getting to the end of TB treatment. But I think it was and as a doctor who treats TB patients, it is something that we worry about, especially MDR TB treatment, or the drugs that we used to have, is, the toxicities of the drugs we worry about. We never want to do any harm. But it was interesting for me to think about how specific the app was really in wanting to only capture that information, even if it had the capacity to do other things. By its nature, that was how it was the focus of it. So I just wanted to make that point.
Yeah, absolutely. And I think this study kind of illuminate how complicated the work of healthcare worker when it comes to management of AE, because for them AE is not just reporting what they're experiencing, but actually, like I'm about to proceed, it is emotional support. But a lot of the time, the emotional support is actually the condition for people to open up, to talk about for the patient to talk about their experience. So through that, we can identify AEs. It's not just about AEs reporting specific type of symptom and AE that might So go ahead and take your point, Sarah. Sorry.
No, absolutely. I was just going to extend on that point, that often, whilst we may all have an appreciation for different reasons of the breadth of concerns that we should be considering, it's interesting how much sometimes the methodological devices we use, as in the study designs we use, narrow the questions that we are asking. So the function, to some extent, of being able to do a trial which is able to compare two concrete things narrows it down to adverse events, which then narrows down the way the app gets used, which then narrows down its application. So sometimes we think about the study designs and methods we use as entirely neutral in terms of the knowledge that we find, but actually it frames the essence of the question and then kind of funnels it down from there. So a challenge can be our desire to have something so concrete that we can demonstrate in a randomized control trial actually really does shape the nature of what we come to know and what we come to do. And I think that's much more problematic than we often give it credit for.
Great. So if I might, I will continue with the presentation, and feel free to jump in if you have any question. So what happened is that healthcare worker and patient tend to move to other means of communication, which is more direct communication, which is phone call and visit to the clinic, or use a media app like Zalo in Vietnam. It's a local social media app. However, what we found is also the adverse event management outside of the app within the routine care were actually quite uneven. So healthcare workers tend to prioritize their attention and care towards certain group of patients who they deem quote unquote more at risk of AEs, such as older people, those who with comorbidities and underlying health condition. While this approach seems to be understandable, especially in the overstretched health system like in Vietnam, where a single doctor is kind of responsible for so many patients, it kind of go against the principle of AEs management, because adverse event, as you might know, can occur unpredictably. So among those similarly healthy MDR TB patients, it's really they can develop some AEs as well. So this kind of selective practice was something that the healthcare worker were often reluctant to acknowledge before the introduction of the vSmart of the app. So when we briefly asked them how they monitor AE during the development of the app, the response tend to be reflective of the ideal procedure rather than what they actually happening in practice. So this kind of illuminating what the gap there within the system. So, but AE reporting actually increased. So what really happening here? So the app So the app being introduced at the beginning become the symbol of care. That actually it empower patients to communicate more with healthcare worker. So for patient, the app become a permission to talk to healthcare worker. So they become more confident in telling healthcare worker how they feel, and therefore patients start to report their symptom more often, more frequently. But ironically, it's not through the app, but actually through other mean of communication. So as the result, there's an increase in workload for healthcare worker. Patients can contact them more often because they feel that they are allowed and they are able to do so. Meanwhile, the app did not accommodate such increase in AE reporting because it sat outside and disconnected from the digital infrastructure of the health system, and healthcare workers have to operate at capacity with limited resources in Vietnam. So did in result result in the situation where patients actually they like the app so much, but the healthcare worker consistently report they are really dissatisfied with the app. So it's really paradoxical, as you can see. So taking on together, what happening beyond? Sorry, Gail, I'm with stop.
I wanted to ask Duy whether the trialists of vSmart, whether prior to developing the app or implementing the app rather, whether they knew that there was this means of communication between patients and healthcare workers, where they were using other means of communication apart from, coming to clinic for a clinic appointment and being seen at that stage, whether it was, I think there were 2 different clinics, wasn't there?
Sorry, Gail. You're on mute, sorry.
I'm sorry. I was going to ask, I can be more succinct now, is whether the vSmart trialists knew whether there was already this way of communication between healthcare workers and patients utilizing phones, whether they knew that patients had the ability to call up, or some of them call up their doctors and speak to them on the phone, or the healthcare workers and speak to them on the phone before they implemented the app.
Yeah, I think to some extent the vSmart team kind of know that there existing mean of communication. However, those kind of way of communication kind of being deemed as like not the standard for AE reporting, because like you said, like healthcare worker can prioritize people, and then you don't really know what exactly they communicating. So for example, in Australia, I know you have Pacific Way where you can report AE, and then there's system to set up. So basically, it's kind of the informal communication, like calling people and then using Zalo app. It kind of being seen as like informal communication. It's not really seen as like the standard that we have to live up to, and then the app kind of become a tool that like seem like to be like try to correct that kind of mistake. But unfortunately, when it comes to it, it kind of create a friction between what already there and what we're trying to accomplish. And then you can see that according we try to do it in the standard way, but like we have to think it in the context of the healthcare system. We don't have the digital infrastructure is not really up to par with what you have in Australia, in all other country. So we have to really think about it, because sometimes we think we introduce an app and then it kind of magically solve the thing that we think it's kind of problematic before, but actually not. It kind of create more problem for us. Sorry, I think Harry have.
Hey, I just was wondering, what is smartphone ownership and smartphone access like in Vietnam? And this trial, was it a requirement that to participate you had to already have a smartphone and be phone and tech literate?
Yeah, for in Vietnam, the smartphone is very common. Number one, it's kind of cheap now, so you can have a really cheap phone, and even people from low socioeconomic background also can own a smartphone. Doesn't mean that they can use it in the full potential, right? So, but the coverage and the ownership of smartphone, it can already high in Vietnam. We do have some statistics that we include in the paper. If you have some time, we do actually have the statistic in there. Sorry, Sarah, you want to jump in?
Just to say, to follow up on the point in relation to Gail's point about kind of what was the trialist's knowledge, I think it is, again, a broader consideration that we think really this paper hopefully helps illuminate, which is the significance of informal practices in explaining how things actually get done is often, whilst we know it's enormously influential in terms of what happens, it's remarkably striking how often that is pushed to the periphery and given diminished importance when we're trying to think about problems or challenges. And so that's the first thing, is that the opportunity for us or social scientists to generally help illuminate and take more seriously informal practices rather than what's written down in guidance, because there's a disconnect here between how adverse events are said to be managed and how they are in practice, at least. And the second part is that the funding mechanisms for getting kind of research, the cycle of research often means you come with a solution to test, and that doesn't necessarily work that well with the need to take a step back before we start thinking about what potential solutions to test, which is what's going on, what do you need, what do you think would be useful. And so often we start with, there's a general, I think, kind of desire for digital health to be shortcuts to things. So it's very reasonable to start with the question of, if we had this, do you think it would be useful? Then the conversation starts along those lines rather than starting further back and placing more emphasis on illuminating our understanding of informal practices. So I think that's both about the kind of research cycle process, but also what we take seriously in that hierarchy of knowledge about why things happen as they do.
Okay, thank you, Sarah. So I can, there's a last couple of slides, so I can go through this quite quickly. So taking together what happening beyond what being captured through the app data, we conceptualize into the 4 distinct types of use or non-use, being shaped by interplay between the perceived social value and functional value of the app among patient user. So first we can see the functional use, which is the kind of engagement that the app and the intervention can expected to see. But and the participant in this group can use the app as intended. So they find it genuinely useful for reporting side effects on daily basis. However, the number of those people kind of small. So the second one, there's enhanced use. So like the first group, the user rely on the app for practical function, but they also use this as in a symbolic way as a tool to build and maintain their relationship with healthcare workers. And the third is the more common among participants, which is performative use. Here, the engagement with the app is largely symbolic. So participants interact with the app not because they found it inherently useful, but because it helped them to meet healthcare worker expectation and maintain good relationship, so they can have access to healthcare worker support on the time. So it was very common for people who are in this group, and when being app, they really like the app, but they don't use it as much as we expected. And then the kind of group of you cannot drive the pattern that you see. They like and they use the app at the first, but over time they find other way kind of more useful, and they already have the attention and care and the permission from healthcare workers, so they don't see the point of going back to the app again. So finally, we also identify the group of participants who face quite more structural barrier to engagement. Their limited use actually reflect multiple and compounding challenges such as low digital literacy, limited income, old age, and absence of carer within their household. And you might expect those who fall in this category, most of them did not use the app, or they have to find someone else to actually use the app or perform what the intervention request them to. So the conceptual category grounded in the interview data offer the more nuanced understanding of user engagement rather than viewing just simply use or non-use. It highlights more complex and relational way people interact with the digital tool within the wider context of MDR TBK in Vietnam. So what does this all mean for designing and implementing mHealth intervention? So improving patient-centered care through mHealth cannot happen in isolation from the broader health system strengthening. The app and the intervention need to be designed and implemented in a way that actually address the structural barrier and leverage from the existing what already there in the system, rather than try to work around them. So based on this, we suggest that we need to have more participatory or stepwise approach to design and implementation of the mHealth intervention, instead of trying to create a quote unquote a killer app from the beginning and not try to lock in the design from too early, but rather than allowing space for adaptation and engage with the user continuously to learn from how the app actually fit in local context, and we can adjust and adjust its feature and strategy accordingly along the way. So ultimately, mHealth intervention need to be responsive to the changing reality of the system and the community that they enter. So this kind of understanding only emerge through ongoing and collaborative and learning during the implementation. So that concludes on the finding of our paper. So we encourage you to go and read in more detail our paper here. So, and then we love to hear your opinion, your thought, your reflection, and happy to take on any question that you might have. Thank you so much.
Yeah, thanks a lot, Duy.
Thanks, Duy.
It's fabulous to hear some qualitative research, and yeah, how valuable. There's a few comments from Steve Graham. Steve, I wonder if you might be willing to talk to these. Also for the recording, because then on the recording people can hear your wisdom as well.
Yeah, thanks, Harry, and Gail and everybody. No wisdom from me. I was just really stating the obvious, I think. It's like the sense that my sense is that the app will work best in the hands of people who do really well anyway, in the sort of context, because so much is about relationships. And I've always just felt that, I was just reflecting on previous experience, so I put that in the chat, experience of over 20,000 child contacts in Vietnam, where we actually had very good uptake and completion, but so much of it was about the relationship that was already there with the healthcare worker and the families. And so when you introduce a new tool, I'm not sure how much you add to that. And in fact, that's probably the place where the app will work best, because there's already that trust and confidence. So I don't know, it's just hard to tease it all out sometimes. That was just my point. Thanks.
Yeah, thanks.
And I just, I think that's exactly and so valuable, Steve. And I think it presents real challenges for assessing acceptability of new interventions, often under trial context, because what we're often assessing is how much trust and value is in the relationship of the person asking the patient to take up the intervention. And so it's about, in some ways, the acceptability of the relationship rather than the acceptability of the intervention. And so recognizing that high uptake, enthusiasm, we might be learning about that in relation to a relationship, not to the intervention, is something I think that we have struggled to really take seriously, but is really, really influential in often what happens, and why I think it was useful in this study to look at a pattern of dwindling engagement and try to explain that, because as you say, if we look at it cross-sectionally, it's almost impossible to disentangle enthusiasm for the person asking in that relationship as opposed to the intervention. But over time, that can be more obvious, and often is only obvious because we might have a really successful trial and then just can't understand why in real world settings it doesn't work. And often it's because it's not the same nature of the relationship with the person who wants to do it.
Can I declare, conflict of interest? I'm an older generation and I'm rather clunky with new technology anyway. And I've been through the business of having to deal with teenage and then young adult children with smartphones. And I have to say, when I'm in a clinic situation and people start just looking and playing with their smartphones, I still find it rather, I don't know, disconcerting. But that's just us old guys. Yeah, sorry.
I was. This is such an important discussion because honestly, I felt, and I wrote this note when I read the paper, was that the relationship between a patient who is suffering and a healthcare worker, I think it creates a really intimate knowledge of the patient's needs, and then this deep trust from patient to doctor. And just to be able to sort of distill that into any digital platform just seems, do you think that there would ever be the possibility that we'd be able to distill a relationship like that into something good? And I'm asking this, quite honestly. Like I wonder, we are living in a new age of AI, etc. And I just wonder, and as we have artificial intelligence now to a point, even in some instances replacing true relationships because they can mimic it so well, will there ever be the possibility that, particularly in places where we don't have sufficient care that can be provided, we could have digital health technology provide a more holistic, not just do you or don't you have abdominal pain, take an app and then get a response from a healthcare worker, but a digital technology that could replace a relationship? I mean, it's a bit out there. Sorry, it's a random question.
I'm not sure if anybody wants to jump in with responding. I think that one of the challenges we have is it can certainly be a proxy, but is it equivalent? I think that's important. And if it becomes a proxy that then becomes part of that delivery of care, is that necessary? Like, is that a good thing? And is that trustworthy? And what kind of manipulation can that be susceptible to? But certainly what we found was it became a proxy for care in terms of patients being valued by the healthcare workers. And you wouldn't have developed this app if you weren't trying to help us. And so there's an idea of value that I think is constructive. And also the potential for as we're already seeing, the ability for it to become much more delicately responsive to needs. So for the purposes of the trial, it had to have quite a relatively narrow definition of adverse events that I don't think need be a limitation at all. It could be much more responsive to the broader context in which somebody's experiencing health and TB treatment. So I think that there are enormous opportunities, but whether proxy is equivalent and whether it's consistently trustworthy is, I think, really huge questions for us to kind of grapple with.
I was wondering if you looked for, or do you think there is a generational effect? Getting back a bit to Steve's point about, there's a huge generational difference in how much and whether people use their smartphones and how you communicate.
What do you think we saw, because of those 4 categories, we were able to see the difference in generational use. And so my impression of it would be that the younger participants who were more comfortable and confident with it still used it as a way of kind of having that permissible access to healthcare workers and circumvented the app after some time. Very few relied on the app. So in in some ways that generational divide might indicate early use, but doesn't necessarily explain the ongoing patterns. It kind of converged a bit more. So what would you say?
Yeah, that's something it took us by surprise as well, because we thought that like the younger generation going to use it in the way we expect them to use it, but it turned out it's still the symbolic factor that influence their use pattern. It demonstrating like, although we see the younger generation as more like tech savvy, but like it's really not. Also, they are human. They are patients who need care, and they when they start to develop TB, it kind of put them in the vulnerable, and that relationship and care and attention is still really important to them. So it can really took it by surprise. So I think that reason why the performer to use, which is a more productive way to categorize user compared to a lot of time when you read in the mHealth space, where you only see younger people and older people. But it's not the way the way we delineate the generation. It cannot really hard to capture the intimate relationship that the younger generation also develop and as a person and also as a patient that they need to. So they need emotional support too. So it's not just functional and app use. So, yeah.
Thanks.
A question from Niloy. I was wondering if Niloy, you wanted to.
It's not a question or just out of curiosity. I was thinking whether the trialist or Duy and Sarah, you or another group conducted any formative study to design this app before, or you just like doing assessment. It could be before. And is there any stages before any research to inform this app design and the implementation of it?
So I take on this one. So there's a phase where they involve patient in and then healthcare worker to design the app. But however, we need to recognize that's like there are a lot of the problem and also the practices is not going to come through when you just engage at the beginning. For example, with the uneven attention and practices that we know about how they prioritize certain group of patients, which is something it's really hard to admit and understand and when you are at the beginning. So we can have the meeting with them, but it's really hard for them to actually think about their practices as the problem to be addressed. So this is the reason why we need engaging across the implementation, not just at the beginning or at the end. So because a lot of problem can manifest during the implementation itself, it's not just at the beginning. So hopefully that answer your question, Leon. Sorry, Sarah.
And just to add that the formative work was once a decision had been made that an app was the way forward. I think that's the key part of what we were talking about, the recognition of informal practices and starting further back with the questions about kind of what's going on, how are things functioning, and how often people within their own health systems have excellent ideas and solutions, but often the ideas and solutions that get taken forward are identified by those who are external to that system. And I think, again, it speaks to sometimes the research kind of production cycle, which means you have to have an idea to get the process going. Whereas I think formative work needs to be thought of in a much earlier version of it, which is like a kind of situational assessment, contextual understanding, rather than around moving towards an agreed idea, instead thinking about identifying ideas. And although this seems really obvious and straightforward, there are very few funding mechanisms for that work to actually take place in ways which are fair and equitable. So I think this is a challenge we face, and what we were trying to do is illuminate some of these tensions in the kind of the production of evidence that mean that sometimes we go off in directions where we could have started off in a different place had we begun with a more open approach to what the problem might be.
Yeah, I also want to emphasize that, like, within the mHealth in literature, we don't see example of vSmart all the time, and then vSmart actually open opportunity for us to do iterative evaluation. So although the finding might seem to be really critical of the trial itself, but you have to recognize vSmart can a rare example where we can start to see the value of iterative approach, and some of the first trial and intervention actually implement iterative approach and take it really seriously rather than it just pilot a lot of the time when you see in the mHealth literature.
And I'm sure we could all immediately think of quite a few funding calls that we've seen which specifically ask for a digital health intervention and apps such as this. So the idea that everybody's open to not necessarily starting with a digital health app, it kind of denies the reality that the funding often exists in that space and not elsewhere. So it's a very challenging area to kind of resist this pull towards apps, and it's often why you can have formative work, but the question isn't broad enough to maybe identify some of these concerns earlier. And I think that part of the work that we could be doing is advocating to funders that digital contributions are really valuable, but it's about infrastructure and it's about what is going to work within a system and a context, as well as just looking, as we said at the beginning of the seminar, these discrete solutions which are beguiling but often not functional.
Thank you. And I'm a social scientist, and Sarah and Duy, you know that, and we work together. And I share those challenges also, all those funding and of doing some social science work. So I totally agree, and I have my personal experience with this. Thank you.
Thanks, Neela.
We'll take a question. I posted a question that we received on by email from Tu Gyang-le, which I think sort of sums this up really. Did we ask patients what their preferences were in terms of what they wanted and needed, which I think Sarah and Duy have contextualized very well. So we'll move on to a question from Alex. You've got your hand up. Please go ahead.
Yeah, that was exactly my question, actually, was given this was patient-centered research, was there the option for people to elect the use of this app or other means to report their adverse reactions? And then also, was there much consultation with the healthcare professionals involved in terms of how it was that they would anticipate the increased reporting of adverse events, and whether there were sort of algorithms, I suppose, for those staff to follow so that they wouldn't be over-promising to patients in terms of the expected response to when those reports were actually shared via the app back to the health staff, if that makes sense.
Duy, do you want me to take that one? So your first question was about whether patients could elect to kind of deviate from using the app. Is that right, Alex?
Yeah, so I suppose for all the reasons that have been highlighted already, digital literacy, health literacy, etc., an app might be more appealing for some cohorts of patients, whereas making a phone call or a visit to the clinic might be a preferred option for a different patient. So I suppose just how the cohort was selected, and whether there was the option for patients to opt into the use of the app or other ways of reporting their adverse events.
Yeah, so happily, absolutely. So first of all, people opted in, and they could consent to take part in trialing this intervention. So that was the patient choice. And then even if they, as we've shown, were engaged in the trial, they often opted not to use the app. So I think the non-use, the uptake, and then the lack of sustained use really speaks to the autonomy with which patients had to elect to engage in the communication channels that they wanted. So certainly there's no kind of suggestion that anybody was doing what they didn't want to be doing. But that's why we were looking at non-use, because in some ways we were saying, yes, I want to use the app, not because necessarily they wanted to use an app, but because of the person who was asking them, and that ability to kind of reinforce that relationship and to kind of be the good patient is how it was considered. And so that's why we're also really trying to highlight that we need to be cautious of not presuming that high rates of uptake indicate high rates of value and high rates of acceptability in terms of the function of the app, because the app was designed to do one thing, and almost from the beginning, the patients used it to do something quite different, which of course is very reasonable. But what it was doing was strengthening a relationship, or finding mechanisms to have permission to then actually give healthcare workers a phone call, etc. So it really tells us a lot about practices, not necessarily about the alignment of the app's functionality with patients' needs or preferences. And then the second question, which was around consultation with healthcare workers, I think that's a really important point, is that, again, within the constraints of not necessarily having spaces to talk about informal practices, healthcare workers, when consulted, were very keen to help improve reporting of adverse events because of the consequences that might have on improved TB outcomes. So the response was generally, yes, we want that to increase, rather than necessarily thinking about what are the consequences of that increase in adverse events on the system, which is what we were saying needs to very much come into the design in terms of its operationalizability and its workload and the systems into which it goes into. Because again, often what we focus on is the discrete intervention rather than the digital infrastructure into which it's going. So some of the challenges that were encountered was because you had this quite sophisticated system, but not necessarily the equivalent infrastructure to absorb that information, which is part of why it was designed to make things more efficient, but it didn't necessarily have the kind of digital plumbing system to flow into, if you see what I mean. So that was also a problem.
Yeah, thank you.
Yeah, well, we're getting close to 1 o'clock. I'd like to thank you both so much for presenting and really opening my eyes to these qualitative approaches. And I think you've really demonstrated the value of it, of the iterative approach of starting with asking people, what do you think is the problem? People meaning TB patients. It certainly made me think about the patients that I treat, particularly the younger ones who don't seem to be very comfortable coming into a clinic to see a randomly selected physician with many degrees and things, that they tend to send a text message and the TB nurse outside my clinic door comes in and says, this is what's going on with the patient. They're not here. They don't want to talk to you, but they are taking their pills. And yeah, so
I think I agree, Harry. I mean, for me, I think that the V-Smart trial and the qualitative work that Sarah and Duy have done and the group have done that accompanied it are, I'm so sorry, there's a phone that keeps ringing next to me. It's not mine. But it's been so important, because really what it highlighted for me, even though that maybe the app wasn't a success in the usual definition of success, but for me it highlighted the emotional need, our need to cater to the emotional needs of our patients, and how in the healthcare system at the moment we have no capacity to do so, but that's really what they're asking for. The app represented a license for them to say, actually, you do care and I am allowed to ask. And that for me is person-centered care. That I think it's a representation of person-centered care. And I'm biologically trained, etc., but more and more as I journey through my career, I sort of keep coming back to, at the end of the day, we're people, and we're not just kind of animals that get drugs and don't get drugs and get better and don't get better. There's a whole mental, emotional context in which we live, and it is it's a little bit embarrassing that science sort of ignores that context in which we have to be able to do the other biological sciences that we work. So I'd really like to applaud Sarah and Duy on this work that you're doing, that you're continuing to do. And I wanted to say also that, Sarah and Duy, what I've noticed of late has been that even though you're right, the grant calls really have had, they're so specific, and they're all asking for, what's your magic bullet that we're going to be able to fix X population from X disease? But more and more, they're asking about community advisory group involvement. They're asking for co-design. I know because in the context of just having to do one at the moment, it's all about, have you asked the people who are affected by this about what they need and how this is going to influence the new thoughts, the new ideas you're going to bring to changing this? So it's good to see. And I think that your study and the V-Smart trial really highlights the importance of what, Sarah, you said at the beginning and throughout, which is it's no point coming in with your perceived magic bullet if you don't understand what the problem is in the first place. I've said it in very simple terms. Sarah, you put it much more eloquently than that. So thank you so much. We had a couple of other questions from some other people that we haven't had the opportunity to read out, but I will email them to you, Sarah and Duy, and you can respond to them. We've got their email addresses. And one last thing, I guess, is we're just on 2:00. I would love to have your feedback, please, on this session, or anyone in the past as well. So Nashita will put the link in the chat, and love for you to complete that. I would like everyone to please help me thank Sarah and Duy for this amazing session. I loved it. I loved discussing this. It's fascinating, and I think super important for all of us to think about how we go forward in our work.